constraint in terms of financing healthcare, but then even that does not protect you from getting entangled into diagnostic procedures that do not appear necessary. So, from the point of view of the project that I am leading for providing technical assistance, we have also a strong emphasis on developing the human resources, and their focus is on developing centers of excellence in the provinces and in the rural areas that ensure or that help to maintain the level of knowledge that graduates from the medical faculties bring and are supposed to use, but they often are not able, or in terms of time actually, time that they have for their own upgradation, to improve this knowledge or to maintain this knowledge even. Maybe because they do not have a type of patients often enough, or maybe they just do not have the access to the information. So this is a host of factors that I see as an outsider in this system, and as an expert who is coping with a couple of components of the sector that combines into how one single person is treated, how one single person is met in the facility, and given the confidence that not only his or her illness will be treated or ailment will be alleviated, but also that this person does not need to worry about the payment. If I'm having to deliver a baby and then think about all the while how to escape from the hospital, I do not think that this is a very healthy situation either for the baby nor for the mother, and of course not for the hospital that seeks to get the cost reimbursed. So there, I see the areas of management in the facilities as an important area, which allows the navigation, which is tied in with the hospital or clinical governance, and then also in this connection of elements, one would want to settle the management of the patient to enter into the right level of care, so that there are no unnecessary costs and that there is the right level of treatment for example, a simple element that should not be treated in the tertiary level. I also see that the payout role still needs a lot of development, and altogether the governance at the higher level of health system needs to be tied in also into proper contracts between the facilities, so that it is sure that the patient gets the right care at the right level at the right facility. So these are roughly, in a nutshell, the observations that I made in the last half year.
Thank you. Okay, just one reaction, and then it's 12:30, so I think...
One quick action. While I'm sympathetic with the experience of Germany, our situation is very different. For example, they have very high level of employment, the level of salary is very good. In the guild system, the employer actually contributes to the premium that is being paid in the insurance system. That will not happen to us. Any president who increases premium, especially at the lower bracket, those receiving 12,000, 20,000, increase it to 10%, we will have a revolution in Iran. I think a universal healthcare system in a country like ours will have to depend, I'm not saying exclusively, but heavily on tax-based funds, just like our sin tax, where you automatically get the tax without imposing or diminishing the take of the individual.
Thank you. Secretary Garin, please. So we'll take one comment from the floor, and that's Secretary Garin, and well, I see John Dee's hand, so we'll close it after John Dee.
Just one, I really want to comment, but I I heard the input from the patient sector. And of course, hearing the experience of Mr. Picasso and Dr. Wong. You know, my take here is, yes, it's not perfect. We have a lot of problems. We need to innovate. But we have one very powerful institution to cover the gap in a devolved healthcare system, and this is PhilHealth. Let's say, for example, Lagundi. I'm just taking this as an example because I'm trying to recall the figures. We did it out together with the Breast Cancer Medical Access Program. The winning bid price in the department, I think, is 1 peso and 10 centavos. I'm not sure, it's something around 1 to 10. But if you go to PhilHealth, how much is it being reimbursed in a small LGU hospital? 5, 8 pesos, sometimes 10 pesos. Go to a private hospital, you reimburse the Lagundi for how much? 14 pesos. In other words, the benefit that we have been giving isn't producing impact. When PhilHealth increased the coverage for medicines, because this is where the out-of-pocket expenditure is high. When it was increased, let's say example, from 1,500 it was increased to 3,000, what happens? The other healthcare providers, they would just increase the cost of medicine. That if you buy it, it's 100 pesos, but if it's charged to PhilHealth, you pay 180 pesos kasi sasabihin nila, utang. In other words, there's much power and room and leeway to police our routes. I've opened this up with PhilHealth. When you mentioned, Mr. Picasso, the issue of maintenance medication. I know it cannot be done immediately. It's not an overnight solution. But if PhilHealth is paying more, much more, for the same medicine, the same brand, the same generic, compared to what the other institutions are paying, then it's time for PhilHealth to enter the market and be a huge player. The biggest consumer of medicines is PhilHealth. And if you can control the prices insofar as cutting the in-between, and that also includes the provision of quality medicines, then we solve a lot of problems. Many of the medicines being procured at the local government units, quality-wise, we do not know what's happening there. It's an issue that should also be addressed. LGUs are investing, but what kind of medicines are they buying? What kind of branded generics or generics are they buying? Are our patients getting healthier or not? I will assure you that we will be in PhilHealth, and in the chairman, in the board, as in the office of the chairman, come up with a proposal. There is a political will on the part of the legislative measure that should be done, but it's a proposal on the take for the next administration to implement, and we will be helping. That is for PhilHealth to be a major player in the provision of medicines, wherein you provide, especially for LGU facilities, so that the allowance for PhilHealth benefit is maximized. If you say this patient needs 20 capsules, that can be provided by PhilHealth, because once we proceed with refunding, the 10 capsules allocated will end up to 3 capsules or 3 tablets. In other words, PhilHealth cannot go on saying that we cannot do it because we cannot procure medicines. We cannot do it because it is not in our mandate. We should start thinking, if it is not in our mandate, how do we move forward? If the benefits is not maximized by the enrollees, how do we move forward? And I do think that in the presence of PHAP here, many of you actually sell your products at a reasonable price. But when PhilHealth reimburses it, especially on some sectors, or when some of the small LGUs buys it, it's very exorbitant. That, in effect, is a big question on how we will achieve health equity. Thank you.
Okay. So last comment, Shondy, then I think we'll have to close.
I was going to ask whether we're eating, but I'll point out a question that's been bugging me throughout the whole morning, and that's to pose another facet of what Secretary Garin has pointed out, and that's not just PhilHealth paying, but on what PhilHealth pays for and what patients pay for. Secretary Garin pointed out that the biggest cost is medical goods, most of which are sold by people here. I might lose my lunch for saying that, but also there's a need for cost containment. And I'd like to ask Karen, because Karen comes from pharmaceutical, and she's in Patient Rights Now. is there hope for addressing this issue of cost of medical goods? As we go to this afternoon session, I was wondering if, from your perspective, you could see what can be done by the pharmaceutical sector itself, by industry itself, so that we do not see IV meds as being used as shackles and the cost of medicines as a burden that brings our health status down.
Karen, you wanna?
So I've worked with pharma for the past 20 years, and there has been significant change in the way the companies have been operating. And there are many access programs that many companies have institutionalized and have started to implement. And one of the major changes that I've seen is tiered or differential pricing. So it's a special price, especially for all procurement or government tenders. But I think the challenge is really for the innovative medicines, but because that's where most of the companies here are focused on. And while there are no longer blockbuster medicines, there are very niche medicines. Many of them are biopharmaceuticals and oncology products, vaccines, and other biologics. So, but for NCDs, there are so many affordable medicines. And in fact, DOH has procured medicines for diabetes and hypertension, and even PhilHealth is reimbursing, at least for the sponsored and indigent segments of society, a lot of these medications. So I think the challenge will really be allowing the companies, manufacturers, distributors, drugstore outlets to participate in the process, because that's one observation I noticed. The public sector is very wary of the private sector, and vice versa. I mean, the private sector sees government as very bureaucratic, slow to implement and execute. But that's why I know the call of Secretary Garin to really put together collective efforts, because no one party has the monopoly of expertise, knowledge, and much less good intentions. So I really welcome a more inclusive process, not just in terms of evaluating medicines, procedures, technologies, but also looking at policies. A lot of the innovative solutions can come from many sectors. And John, did I answer the question?
Thank you, Karen. So thank you very much. I think we have to end there. It's 12:40 and we still have an afternoon session. I'm just going to summarize by giving keywords that actually came up. And consider these keywords as loose ends and work in progress. The first keyword, there are about 8. The first keyword is patient-centered care. The second is expanding primary health care. The third is choosing priorities, looking at the burden of disease. The fourth is figuring out the evolution. The fifth is considering PhilHealth premiums and maybe even socialized pricing. The sixth is quality assurance of hospital services. Getting the right level of care and the right rationale for care. The seventh would be policing our ranks. And then the eighth would be PhilHealth as strategic purchaser. And possibly, I would like to end simply with one big idea that really, as has been mentioned and echoed by many speakers, we are the health system. The people in this room, whether you're a provider, a financer, a user, we are the health system. And the interactions of all of us are going to determine whether we deepen and widen access and cut our costs. Thank you all very much. I'd like to thank all of the panelists for their participation, and I'll turn over the floor to them. Thank you.